right. Welcome back, everyone. Welcome back to our online audience. We did hear from Mike. He sends his apologies. One of those time zone things. So, as we come in, so 2 years ago at the Broken Arrow, the theme was digital health and clinical trials. And one of the things that was introduced was the clinical monitoring and biomarkers study, which was a feasibility study looking at the incorporation of Bluetooth devices in a feasibility study on the incorporation of Bluetooth devices in studying. And it's a pleasure for me to invite Claire Edmondson to give us an update on that particular study. Claire is a pediatric respiratory registrar. I'm not sure what that means. A registrar, a respirologist from the United Kingdom. She's completing her PhD with Professor Jane Davies at the Imperial College of London. And her PhD, which is funded by CF Trust and Cystic Fibrosis Canada, investigates the feasibility of remotely monitoring children and young people with cystic fibrosis. The study explores the usage and practicality of a specifically designed mobile phone app with integrated Bluetooth equipment, as well as investigating the impact of home monitoring has on the mood and quality of life of participants. Please welcome Claire.
Good morning, everyone, and I'd just like to say thank you so much to the organisers for inviting me to come and talk about my project, Climb CF. So I just wanted to start with a bit of background about why home monitoring might be beneficial. We know that infection and inflammation starts early in life, and that structural and functional changes can be seen even in young children. So our aim should be the prevention of decline in childhood to ensure that adults can achieve their full potential. Currently, clinical status in CF children is assessed at intermittent hospital visits, irrespective of clinical severity, and unlike for asthma, home monitoring is not routine. We also know that people with cystic fibrosis experience pulmonary exacerbations, and that these are associated with a worse prognosis. Delay in recognition of these events is common, and more sensitive diagnostic tools would potentially allow prompter treatment and may improve outcomes. We also know that people who experience pulmonary exacerbation, 25% of those fail to recover their baseline lung function, and that they're associated with poorer quality of life. There is the potential that home monitoring may predict these events earlier. Not only that, it is possible that our current form of monitoring is suboptimal. It's cumbersome to families. Children have to miss a lot of school. Parents have to miss work. Sometimes they have to travel long distances to get to their CF centre. Appointments are scheduled within a really rigid healthcare system which doesn't allow much flexibility. Visits can be infrequent, and despite everything we do, there is a risk of cross-infection. We do know that adolescence is a key time for lung function decline. This is European data, but along the top of the graph is FEV1 % predicted, and along the bottom in bars is the number of people with cystic fibrosis. As you can see, the lung function declines gradually over time until about the age of 12, when there is a sudden drop in lung function, until about the age of 20, when it plateaus again. This is associated with a decrease in the number of people with cystic fibrosis. Could engaging young people with their health in a different way prevent this decline in adolescence? We also know that it isn't just down to the genotype that people have. Again, this is European data, but all of these dots are someone who is homozygous for delta F508. And currently, there is no way of accurately predicting which person at the age of 20 ends up with a lung function of 120% versus which person ends up with lung function of 20%. Could extra monitoring potentially help us identify those people at risk of having low lung function by the time that they're 20 and allow us to intervene earlier? Just before I go on to the specifics of our app, I just want to give you a bit of background about health research and digital apps. And actually, by talking here today, this slide is already out of date. Currently, there are 318,000 apps available on app stores across the world, with 200 apps being added every day. But apps in health research are in the early stages. More advanced research in monitoring apps in asthma, breast cancer, diabetes, and Parkinson's are available. But this graph on the right-hand side shows a pie chart of apps in the UK under research, and the whole of the respiratory system only makes up 5% of those applications. And most of those are in COPD. The EI study has just concluded in America and looked at monitoring using home spirometry to monitor adults with cystic fibrosis to try and identify pulmonary exacerbations. And they showed that 50% of their participants entered data weekly for 80% of the study. The study was over a year. However, it should be noted they were asked to enter data more frequently than that. And a recent study of home monitoring in the UK has just concluded. We're also aware that chronic conditions put people and parents at risk of developing poor mental health. And within cystic fibrosis, there are varying degrees of anxiety and depression reported. This graph on the right-hand side is from the CF Foundation 2015 report and shows patients who were diagnosed with depression in blue and patients who were diagnosed with anxiety in red compared to the total number of people on their registry. We also know that poor quality of life can lead to poor adherence, and the recent International Committee of Mental Health guidelines recommend that we should be screening our patients and our parents for depression and anxiety using measures such as the PHQ-8 and the GAD-7. We also know, and has been touched on within this conference already, that our patients have quite a high burden of treatment already, and we were very conscious that we didn't want to add to that burden by asking them to do extra monitoring at home. So CLIMB-CF is a study looking at the possibility of remote monitoring children and young people with cystic fibrosis. And our hypotheses were that in parallel with current standards of care, home monitoring will be feasible and acceptable to patients and their families. It will provide tools for patients and families to assess their disease. It will empower young adults in self-care. It will not adversely impact on mood or quality of life. And that we'll be able to gather biomarker data to help predict exacerbations. So we designed a pediatric home monitoring app, which was aimed at engaging young people and their parents, and we're exploring the feasibility of collecting data with this app and of collecting samples for biomarker analysis via home collection. So we designed 2 home screens, which you can see on the left-hand side of this panel, and we asked a group of testers for comments, as well as the youth advisory group at the Cystic Fibrosis Trust. I don't expect you to read all the comments, but overwhelmingly, option B was selected, with comments such as, it looks quite fun and funky, it looks more modern. Generally, they just preferred the look of option B. So this is what the final app looked like. On the top left-hand panel, you can see the home screen, which has 5 separate tiles that patients or parents could select to go into submenus. Below that, you can see our wellness questions that people were asked to complete using an emoji-based ranking system. And on the right-hand side, you can see the submenu that was attached to the Bluetooth devices and the instructions that participants followed to record their data. All participants were recruited for 6 months, and they were given a study phone with a pre-downloaded app on it. They were asked to collect measures either daily or twice a week. They were asked to answer their wellness scores daily, do their heart rate and oxygen saturation, their temperature, and wear an activity monitor daily. They were asked to weigh themselves twice a week, and if they were 5 or over, they were asked to carry out their lung function twice a week. There was also a diary element built into the app that they could utilize how they wanted. On average, it takes 5 to 10 minutes a day to complete. Prior to the CLIMB-CF study, a selection of adult and paediatric patients at the Royal Brompton Hospital were asked which samples they would, in principle, be willing to collect at home. We had 56 respondents. The majority of people said they were happy to collect throat swabs, urine, or nasal samples, and 49% of people said they would be happy to collect dried blood spots. So as part of CLIMB-CF, participants were given the option of collecting all or some of dried blood spots, throat swabs, urine, nasal secretions, or sputum at home. They were asked to collect those samples weekly, and then if they became symptomatic, they were asked to increase the frequency of sample collection. As I mentioned earlier, we were concerned about increasing people's burden at home and worsening their psychological well-being. So built into the study were several well-being and mood measures that people completed up to 3 times over the 6 months. So parents completed the PHQ-8 and the GAD-7 for depression and anxiety. If the participant was over 6, the participant and their parents completed the CFQR. They completed the Strengths of Difficulty questionnaire, and they also completed the Knowledge of Disease Management for CF and the Self-Reported Adherence and Barriers questionnaire. So we opened 6 sites in the UK and 2 sites in Canada. We opened the Royal Brompton Hospital in London, which is where I was based. I opened Great Ormond Street Hospital in London, the Royal Alexandria Hospital in Brighton, Alder Hey Children's Hospital in Liverpool, the Great Northern Children's Hospital in Newcastle, and we had 3 hospitals in Scotland that came together as the North Scotland Collaboration. In Canada, we opened a site at IWK Health Centre in Halifax and Children's Hospital London Health Sciences, Ontario. So today I want to show you some of the preliminary results, and I also want to make you guys aware of some of the lessons that we've learned during this study. Within the time period, our aim was to recruit 160 people. We managed to recruit 148, split, as you could see on the slide, by site. We had 3 people who failed screening or withdrew prior to starting the study, which gave us 145 active participants during the study. We had 11 that withdrew during the duration of the study. I just wanted to show you some of the reasons for withdrawal. Interestingly, quite a high number of reasons for withdrawal were based on social circumstances or change in the social situation, as well as some around equipment frustration, and 1 participant just lost interest. So this is the age distribution for the total study, UK and Canada. Due to the limitation of some of the Bluetooth equipment, we recruited children who are aged over 2 to 17. When you look at the Canadian sites themselves, this is the spread of ages of participants within Canada. Again, when you look at both the total cohort and the Canadian cohort, we had more females than males in both cohorts, and the median age of participants was 7 years and 11 months. So I wanted to show you some of the data completeness and the data that we've been getting back from the exports. So just a bit of background, participants were not given a specific time of day to enter data, but were asked to enter data at roughly the same time of day every day that fitted in best with their schedules. They could only enter 1 data point a day, and that could not be altered. And it was not possible to retrospectively add data. When I started looking at the data exports, the data export revealed occasional duplicates of data on the same day in the UK data. However, I noticed significantly more double entries in the Canadian data. These appear to be connected to the database converting all of the Canadian data points to Greenwich Mean Time. Initial attempts by the software developer to correct for these have been unsuccessful. Therefore, unfortunately, I'm not able to share the Canadian data with you here because I'm currently manually correcting it all. So I just wanted to give you an example of what I mean by this. So this is 1 patient from Canada on one of the measures that they were recording in a snapshot of a few days. Each set of red squares implies a date that has 2 bits of data entry connected to it. As you can see on this top section of data, both of the data points have been registered at 21:34:02 with the same rating. And this is an accidental duplicate within the data, and these are very rare throughout the whole data set. However, in the Canadian data, we have data points like this, where there's no data entered for the 15th of June, and then on the 16th of June, I have 2 readings, 1 just after midnight in the morning, and 1 late in the evening on the 16th. This implies that the data just after midnight was entered in the evening of the 15th in Halifax, and the conversion to Greenwich Mean Time has put that onto the 16th. It's a big task. I also don't expect you to see the detail on this slide, but this is all of the UK participants and all of the daily measures apart from activity. So each column is a measure and each row is a participant. Those rows that are, those cells that are coloured green suggest that greater than 60% of the data requested has been completed. Yellow and orange is 60 to 30%, and red is less than 30%. I think that this slide kind of implies if you've signed in to complete one measure, the chances are you would complete all of the measures. So looking at the UK data in a bit more detail, the median requested daily measures completed was 39.4%, and I had 14% of participants completing greater than or equal to 80% of all measures requested. When you split that into age groups, 2 to 7-year-olds completed just over 46%, 8 to 12-year-olds completed 44.7%, and 13 to 17-year-olds completed only 16.8%. I also wanted to share some of the participant and patient feedback that I've had so far. So that comments such as, I think the app is a good tool, I like seeing the monthly progress data, but some days were harder to fit into an already very busy schedule. Irritating when the activity monitor wouldn't connect or load, but generally enjoyed being part of the study, will continue to use the app. Having time was hard, the phone was a bit poopy. That was one of our participants. It was a brilliant opportunity for us to be able to keep checking his health. It's the best decision I've ever made. And as I'm a lone parent, it impacted on my home routine and raised my anxiety. So just wanted to share some of the lessons that we've learned in trying to organise this international study. There are differences in data protection laws, especially with transmission of data internationally, that need to be taken into consideration. Unfortunately, due to timing, we couldn't carry out a thorough testing period in Canada of all of the Bluetooth devices and the application, and for some reason, the lung function monitor would not sync with the Canadian phones. Unlike the UK, where the ethics process is now centralised, you have to allow for REB time at each Canadian site. I provided all of the tech support for all of the sites, so the differences in time zones meant that some of the Canadian teams were contacting me late in the evening and I wasn't able to provide immediate tech support. And I think I've shown you the effect of the time difference on the data exports that I'm dealing with. So we've got quite a lot of ongoing work as part of this project. I'm in the process of analysing the Canadian feasibility data, and I'm in the process of analysing all of the mood, anxiety, and quality of life measures. We're starting to think about machine learning of the data around exacerbations and trying to identify the minimum amount of required data to make this modelling work. Does it need daily data, twice a week, weekly, etc.? And we're looking at the biomarker exploration using the home collection samples to predict exacerbations. I just wanted to end on this picture, which is a view from one of our Scotland's participants' houses, as I think it quite nicely summarises why remote monitoring might be so beneficial to some of our patients. Thank you so much for listening. I'd welcome any questions and comments, and I'd really just like to thank the Cystic Fibrosis Canada and both of the sites in Halifax and London for all of their hard work in making this study possible.
I have a question.
Yeah.
My name is Chris again. You said you hypothesized that this project would not adversely impact mood and anxiety and whatnot.
Yeah.
And I'm wondering if you took any preventative measures to ensure that as part of the study, or was it just a hope?
Yes, we didn't take any preventative measures, but we gave clinics clear guidelines of when to intervene or refer should a score change based on depression or anxiety throughout the study.
Do you think that there's any connection to lower participation rates in your older subjects because of issues like that?
Possibly. I think it's possibly a bit more connected to, unfortunately, because of limitations with the study, we could only produce one application and one interface. And I just wonder if maybe we weren't hitting the adolescent market as well with that. Because I think ultimately you need a parent portal, a kind of 8 to 12-year-old portal,
Sure.
a teenage portal, those kind of things. So I wonder if it's more connected to that than... But I haven't analysed all of the data for
Thank
their
you.
mood yet.
That is really quite interesting, and actually in the breakdown between pre-adolescent and adolescent. So perhaps I missed it. Did they get a reminder, like, we haven't heard from you in a couple of days, where are you?
Yeah, so they don't get a reminder. We decided deliberately not to get a
Okay.
reminder so that they would get, we'd get a bit more real life data. The app itself did have the option of setting both a daily reminder and a twice weekly reminder, so that if you decided to do your lung function on a Sunday and a Thursday, for example, you'd get a reminder back. And we do have the ability of looking at how many people utilise that reminder facility.
Okay.
I haven't managed to look at that yet, but the data is there.
Okay. And to follow up on the last one, have you thought about going back to the adolescents, all of them, and sort of asking feedback on what they liked, didn't like, if they used it, why, if they didn't use it, why?
Yeah,
because
so-
rather than trying to surmise.
Exactly, yeah. So we did give them feasibility questionnaires at the end that ask those kind of questions. Only some of them have been filled in. But yes, I mean, it would be interesting to go back to them if they would be prepared to discuss their involvement in the study further. Yeah.
Okay, great.
Hello, my name's Julian Tam. I'm a respirologist from Saskatchewan. I was interested in your plan to study biomarkers, especially in the context of your comment about using machine learning. I'm curious to know whether you have actually banked some of your samples or if you've analyzed for a certain particular finite set of tests and are then going to use the machine learning or whatever capabilities to analyze them.
Yeah, great question. So all of our samples are biobanked. So that we do have the ability to go back to samples retrospectively if we want to. Part of the study was to see if people would collect samples and to look at the pattern of sample collection. Do people actually increase their sample collection when they're unwell, or do they increase their use of the app, or do they drop away a little bit because they don't want to be reminded maybe that they're not feeling as well as they were. So we will be able to integrate the biomarker data into the machine learning, but I need to analyse whether we actually have enough samples to be able to give us anything fruitful back. Great. Thank you very much, everyone.